Welcome everybody to today's WebEx, which is the second to last one in our series of Lunch and Learn from the Long-Term Conditions Programme. And I'm delighted to welcome an old friend of mine, Simon Brake, who I've worked with in a previous life, and Steve Vincent from West Midlands Fire and Rescue Service. So with no further ado, I will turn to Simon and to Steve and ask them first of all to introduce themselves and then to take us through their session on fire service as an asset, providing telecare support to the community. And then after their presentations, I'll facilitate your questions and your comments so that we can look at things in a bit more detail with them. So, Simon, over to you.
Thank you very much. I'm going to take about 10 minutes, if that's all right, to talk you through these slides. The context for this is on the next slide, which is I'm the Director of Primary Care in Coventry and Rugby. For those of you who don't know the area, it's a bit kind of south-east of Birmingham, about 20 miles south-east of Birmingham, population of just under 500,000, which is growing rapidly as part of the kind of the Midlands engine. Quite a deprived population in relative terms, not the most deprived, but getting on for the most deprived. We have a particularly pressured health and social care system. So our limited resources and growing demand, combined with our significant pressures over DTOC, which is delayed transfers of care, 4-hour wait targets, we're down in the late 70s for that. Average length of stay pressures within the hospital and across the system have been really quite overwhelming for a number of years, but particularly the last 12 months have been notably difficult. We have tried lots of clever and innovative things within our system, which haven't really worked. Some of them have worked a bit, but we do need to try something else. So I don't know if any of you are familiar with this is part of the Hogarth series. I think this is called Beer Street and Gin Lane. But just over to this kind of scene of chaos, really. There's quite a lot of opportunity in there, and just over on the left-hand side, you can see the sign painter painting the pub sign, and those kind of two beautiful curves of his body in preparing to paint with his palette. So I think we have a system that feels like a system that's chaotic and there's nothing to do, but actually I think there's a great deal of kind of elegance and opportunity to be seen within it if we look properly. So a number of you, again, will know this diagram of how the system works. So this is the King's Fund depiction of the system. It's quite hard to navigate your way through the system of health and social care, how to commission, how to access services. The opportunity for new entrants, new participants, new thoughts to how we deliver health and social care are very limited, and we find it hard, I think, sometimes as health and social care chief officers, particularly to think outside of our normal structures, which we've been working with for 20 years. So for complex reasons, we thought about firefighters. Now, firefighters normally do the stuff we think of doing the stuff down in the bottom right-hand corner. We've worked with the fire service in Coventry really well for a number of years, but on very particular aspects of health and social care. So they've been members of our safeguarding boards, both children and adults, for a number of years. They've worked as partners in supporting older people in terms of home safety checks and so on. And of course, as part of our blue light cohort, we work very carefully and well with them. More recently, they had expressed some views about, and in fact applied for a tender and won a contract for some telecare work, so response to telecare and community alarms. But in terms of kind of delivering core health and social care services, hadn't ever had that conversation really. Fire service staff operational fire service staff are mostly non-operational, so my good colleagues tell me that they spend between 3 and 7% of their time operationally responding to fires and RTCs, and the rest of the time doing other things, kind of the planned work that they do. Sorry, the area that I'd forgotten was men's health and youth work. So actually, the proposition that our fire service colleagues came to us with was one around what other duties, what other responsibilities, what other level of reach could be made by the fire service during the time when they're not responding to fires. And it kind of made us an offer we couldn't refuse, which was an offer to get people out of hospital. So we have a significant problem in Coventry, which is that our delayed discharges are very high. Our ability to get people out into the social care market is very limited, and we're very pushed in terms of resource. We kind of find ourselves at the edge of our ability to do things, and sometimes beyond the edge of our ability, and therefore not able to discharge, and gums the whole hospital up. We aren't able to admit people to the hospital, and we end up with ambulances stacked on the bay. This is a scenario that I'm sure many of you know. When we first had the conversation, our fire service colleagues, with whom we've been working for many years, basically said, well, they would offer us this resource for free, or almost free, which indeed they've come good on. The resource they offered was an operational fire resource. So very early on in the discussion, I said, well, you know, we need you to respond quickly. How quickly can you respond? And they said, oh, we can respond in 5 minutes. I said, well, do you actually mean 5 minutes? Actually 5 minutes? And they said, oh, yeah, from the moment the phone call comes to the moment we arrive with you will be 5 minutes or less. So I said, all right, okay. Well, perhaps not that quick, maybe 2 hours. So what we had was a very agile and operationally responsive service with a number of staff whose job is to care for and make sure people are safe. And the proposition that we looked at was around meeting people at home and making sure that their home is safe. So meeting them home when they've been discharged from hospital to enable the hospital to make a discharge safe in the knowledge that there's somebody at home waiting for them and that their home will be checked for being safe. For this to be available 24 hours a day, 7 days a week, 365 days a year. And working in conjunction with other partners. So they weren't kind of presenting themselves as kind of lone rangers riding over the horizon to come and save us, but actually kind of integrated with other partners. So there was a question about kind of, you know, what's not to like, really. Now, us being NHSE people, there were some questions of governance. We wanted to understand about indemnity and CQC registration, whether or not this constituted personal social care and whether it was a registrable activity. We were quite interested in clinical oversight and the role of clinical colleagues in this. We wanted to understand whether or not this was a health or social care service. I might sound a bit basic, but that was a genuine question. Understanding what the relationship would be with West Midlands Ambulance Service, particularly WMAS, who are our ambulance service providers, both for emergency and non-emergency patient transport. It's within an environment of limited resources and growing demands. And as I said, we've tried lots of clever and innovative things which haven't really worked, and we needed to try something else, and this was it. So there was a question for us about whether or not we were prepared to make that step. There's quite a lot going on at the moment in the health service. There's lots of changes and pressures. There's strikes going on. There's a huge amount of concern about cuts or pressures within healthcare, and the need to expand the quantum is something that has been very pressing. So to bring in other partners beyond that resource that we already have, and this really was it. So Where did we take it? Well, we have agreed a pilot over this winter that was not without some difficulty, because it was a sufficiently different idea that a number of people just found that very conceptually difficult to deal with. We have achieved and agreed a series of standard operating procedures and protocols with partner agencies for the fire service. We're thinking about and figuring through CQC registration issues and thinking about clinical governance and putting an arrangement in place within the fire service that would be recognisable from a health partner's perspective. We're establishing a clear service specification as we're going through this kind of PDSA series of cycles. We are collecting lots of data and information and making sure we have sufficient data to be able to undertake an evaluation to understand whether or not this has worked, whether this looks like success for us. I think we are absolutely agreed that this constitutes an astonishing opportunity. And in the words of Mr. Marks, we have nothing to lose but our chains. There is nothing to lose by us trying this. We have made sure the safety aspects of this service are there. There can be no aspect of this that does not deliver additionality and a better service. So with that, I'm going to hand over to the next slide. Questions, I understand, will be at the end to Steve.
Okay, so I'm coming from, my title is I'm an area commander within the West Midlands Fire Service. And when Simon and I were working together, I was the strategic enabler for prevention. I have recently moved roles, but I had the great privilege of spearheading this on behalf of the West Midlands Fire Service with Simon and his team. So, fire as a health asset. Well, Simon, you know, is a namesake of quite a few people in the NHS. So you keep it simple for us in terms of using the names. And as you can see from this slide, you know, the fire service has a fantastic opportunity to reduce the risk for old people. But I suppose we need to put that into the context of why are we interested in what a lot of people historically say, well, that's a health service issue or a health service problem. Well, we started a journey probably about 5 or 6 years ago of when we were really drilling down of what causes a fire in a home or a fire death. Well, actually, you started to realise that it was the behaviours, the systems and the environments that actually created social inequalities and health inequalities were actually the same triggers that actually created that perfect storm that actually ended up with somebody dying in a fire. So actually it was really, really important for us about, well, actually, how can we support that agenda at the same time being true to ourselves? And that's where we started to really problem solve and work through these issues with partner agencies and actually building these relationships with people like Simon. And with Simon and the people in Coventry, we've probably taken that, what I would call, to the next level and understanding what those problems are. Now, we, you know, as you can see from this slide, started to understand or get an appreciation of the issues and then kind of related into, well, what are some of the simple things that our firefighters do when we go into people's homes on a day-to-day basis that can actually make it a better quality of life, a better outcome for the people in the community, but at the same time actually starts taking away the burden of what's being created on the wider, you know, not just the NHS, but the wider public purse, so that we can make it better not only for the individuals, but also better for us to use the money that we have in the public sector more wisely. So what we have got is we've got something that we call a service delivery model, which we have X amount of firefighters on 24/7, 365. We're trusted and we can give reassurance, and we believe we have a proven track record that has been tested over the years by the Audit Commission, recently by the National Audit Office, in terms of delivering prevention. But what we're really good at is actually problem solving and looking at in terms of what in practical terms means that person. So is it a trip hazard? We go into an elderly person's home that's making them vulnerable. Have they got food? Are they drinking? Is there assistive technology? Who do we need to speak to actually ensure that that person can actually live longer in their own home and have that quality of life? And then when we started talking about, you know, telecare or hospital discharges, we suddenly realised actually you can actually signpost us to people who actually we can start working with far further upstream. So we can actually look at that person not going back to A&E 7 times or being in hospital for 3 to 7 days, or actually in terms of some of the examples that where we've been working, we can actually be part of the process when they come out of hospital. So yes, there's no clinical reason for them being in hospital, but actually we can check out very quickly the home environment to give some assurance before the other systems kick in that actually they have got food in the house, they have got heating, they have got lighting, they have got access to a toilet, because actually they might have an injury that means they can't get upstairs. So we can be the eyes and ears, and at the same time we can look at whether actually what is the fire risk, because the risks that create fire are actually the same risks that create that broken neck of femur in terms of somebody falling over. So again, what we've got is this: we use our service delivery model and our capacity to do that. So we also upskill our firefighters around health and well-being, understanding social isolation and what that means for us as a fire sector, but also how that interconnects to the whole rest of society and other agencies. What we understand is, or what we're starting to understand in a more fuller way, is actually this is a whole system in terms of the life cycle and the vulnerabilities from when they're vulnerable, you know, when you're born, to later on in life in terms of, you know, in terms of the elderly. They actually create risks and likelihood, but actually it's people, and actually these people sometimes just need to have some very simple interventions or signposting that our firefighters are more than capable of doing. So we understand the environment, we understand the complex needs. We're not there in terms of the medical term of complex needs, but we understand that actually they may need a carer. They may need to have medication. They may need to have some interaction with people that helps their well-being so that they actually feel better. It may be, in terms of their environment, they're living in one room and they may not have other contact. So we become part of that navigation system that supports the wider, at the same time, as again, go back to what we do on the tin, which is actually save people from fires. This is part of our upstream firefighting to ensure, ultimately, we don't turn up outside with a blue light on, putting breathing apparatus on and having to go in there and fight the fire and rescue somebody, because we are being part of that more complex system that mitigates or stops that need from ever arriving. This slide talks about us in terms of a perfect week, which is basically a trial, or what I call a development week, that is run in Coventry through the University Hospital in Coventry and Warwickshire, where we looked at hospital discharges and we looked at actually how can we facilitate getting people home quicker and give reassurance that actually what they're going into is safe environment, and doesn't mean to say from discharge they're going to be readmitted very quickly. And an example that we did have was a clinical person. One of the people had dementia, but there's no real clinical reason why they needed to stay in hospital. But in terms of this discharge process in that week, we were referred on. So we went along, and on this occasion, that person had collapsed in front of the fire, left the door open, and because we'd been there, they'd been discharged, and by the time they got home, we'd been there within 30 minutes. We were able to make the appropriate referrals and get the appropriate supporting for that person, so it didn't become some form of catastrophic event. Where another place, we actually went and we were able to check that they'd got heating, lighting, food, water, access to the appropriate utilities. So actually there was a reassurance and give information back to the providers coming in next about, are they going into a single private dwelling? Are they going into a block of flats? What is some of the makeup of the house? So actually when they go, they can hit the ground running in terms of what they really need to make that person's life, you know, and support their life valuable in a quicker fashion. So proof of concept, we're evaluating this all the time. We are seeing in terms of the telecare provision that we're doing, there is a reduction in demand because once we've gone in terms of the telecare, what this is frail and elderly people. It's the provider has basically made an estimation that they've lost contact, but there doesn't seem to be an emergency. So we attend and we see. Now we will then, you know, pick the people up if they've fallen safely because we've done an assessment of that, or if there's something else going on, we've made the appropriate referrals. Or again, if it's just that actually the pendant's gone on, we've then done what we call a safe and well visit and a follow-up to see if there is additional services, whether the assistive technology is supporting them and working with the individual, the families and the providers. So it's the follow-up care and assessment that we do. And this, we go the extra mile and we give that reassurance, and we're a trusted brand in terms of that delivery. And, you know, Simon said in terms of some of the work that we do, the follow-up, actually, that's part of our core duties. And in terms of the initial call, there's a small charge in terms of the overall provision. But in terms of that small charge, in terms of that, how much does it cost if somebody gets admitted into hospital? And what we were finding with the telecare is prior to us undertaking this work, the majority of those calls were being attended by an ambulance, and the ambulance would take them to hospital, whereas over a very short period of time, we have, you know, reduced the number of ambulances that have had to be called because we've been there, made those assessments, had the time to find out what's really going on, and then, if need be, call an ambulance for them to go to hospital. And that's been very far and few between because actually it wasn't a clinical reason that the issue was around. It was more about there was problems with the equipment, or there was more of a reassurance, and it was more about getting to know the individual, getting to know the family about what in terms of what those issues were. So, you know, in terms of LTC, in terms of dementia, self and well visit, response and follow-up visit, and independent living, we have proven that actually we're supporting that. What we're not saying in any shape or form is that we are taking over from other services. We are part of a jigsaw that is helping other services to support that individual within the community to live independently and have a good quality of life. And I'm open to questions, which I'm sure Simon will be as well. Thank you.
Brilliant, thank you. Very well thought through presentation and very well articulated. So thank you both. Hello, welcome. Hello. Put your question.
It's just I've met with a fire officer this week who is looking to explore how public health and the fire service can work better across West Yorkshire region, and we met about a couple of issues this week, but we're looking at training and upskilling the fire service staff, and obviously you've mentioned that you've done some training and upskilling. I'm just interested in what the model is that you've used, who's delivered that training. If you've got any further information on that, that would be really useful.
We've been working very closely with a range of partners, but in particular the Royal Society of Public Health and Public Health England, and different fire services are adopting different models. Now, because of the way we are undertaking our service delivery model, we've worked with RSPH and tailored one of their level 2 health and wellbeing qualifications, where we're doing that through an e-learn capability, so that they can do it in their own pace over their own time, and actually then do an assessment, and that assessment will either be done with a invigilator in a room, or again over a webinar that people can do in terms of those aspects. So it's actually called Understanding Health Improvements is the actual qualification with regard to that. And then obviously we're working with partners in the area in terms of the multi-agency development sessions, as well as they're upskilling their health professionals in the area. If it's really appropriate, then we, in terms of adopting things like the MEC principles, making every contact count, but also what does dementia look like? What does social isolation look like? What are we going to do if we're dealing with troubled families? Because we go wider. I know we've concentrated on today in terms of the elderly, but we do work with the entire span of the population with regard to that.
Yeah, that's really useful. So, so because obviously you've mentioned MEC and we've been looking at MEC. Do you think I'll leave it at this because then I can get in contact at a later date if I've got further questions. But has the two kind of elements of the training together been valuable, or do you think, have you required both elements, both the MEC and the RSPH stuff, or is it something that the MEC could have addressed on its own? We're just trying to kind of work out the best way to kind of upskill, really. Just
I think I've got what you're looking for. So, firstly, let me give you an email address because the person who's leading on that for us now is a gentleman called Pete Wilson, and his email address is pete.wilson@ and I'm going to spell it in terms of Whiskey Mike Foxtrot Sierra, so WMFS.net, so it's our initials of the fire service. He's the head of community safety, so in terms of specific details, he'll be able to advise you appropriately. Now, what I'd say is, in terms of the MEC principles and the training that the local authorities that go to, their officers and their third sector, that was like the starting point. That allowed our firefighters to build appropriate relationships, because that's great, because you get to know who's delivering in the area. Secondly, it built confidence with the other providers in the area in terms of, what's a firefighter doing there? Don't they squirt water and put out fire? So build understanding and relationships about what we're about. And then what we did find is that actually, to give our firefighters confidence, but also to broaden that knowledge, it was well worth getting the development of the RSPH Level 2 qualification, to actually say, not only have I been on a course that's given me an awareness, I've actually now understood it, and I can demonstrate to people that I've understood it. So it gives a confidence to, clinical commissioners in the CCG world that actually, these firefighters, I know they said they've been on a course, but actually they do have we've got been able to demonstrate that they do have an understanding, and so it gives you a bit more confidence.
I understand that. Yeah, thank you. That's been really useful. That's been really useful.
Simon, hang on, Helen. I think Simon might have something to add to that. Simon?
Yeah. If I could. So, I mean, the thing that's a bit odd about fire service staff, and Steve will forgive me for saying this, is the legislative basis on which they work is very different from the NHS. So at the moment, the legislation that you work under, I'm going to get this right, I think it's the 2006 Fire and Rescue Act or something like that.
2004.
2004, I do beg your pardon. And
yeah.
Section 4 is the health bit, which says you can do anything to kind of save life and limb. So your legislative basis is very different. Your regulatory environment is very different. Your licensing and oversight and indemnity environment is very different. So we spent quite a lot of time kind of exploring how that we could make all of that all right and what was okay. So we established that the activity that they were undertaking was not and is not registrable, but we are putting in place a series of steps to ensure that the kind of clinical governance standards that we would ordinarily expect health and social care to comply with is replicated. And at the same time, I know Steve and colleagues are putting in place some systems that would allow us to recognise bits of health service or NHS governance within the fire service. And I think that's really important that, firstly, the fire service isn't over-encumbered by that stuff, which allows it to be fleet of foot and able to do stuff in a responsible way, which is still what fire officers do, at the same time as being sufficiently safe and kind of clinically governed and overseen that we've got the confidence in it that we need. And I think that's been a really tricky thing to do, but we've managed it.
Yeah, that's really good. Thank you.
Brilliant, thank you. And it sounds like you've got a contact to take further questions forward as well, so that's good. Katie Clark-Day, who's my conscience and my voice of reason around reality, I think just wants to make an observation and perhaps a comment to you.
Katie.
Hello, Katie. Welcome. You might need to explain who you are.
Oh, that could take some time. I've actually listened to this with a few hats on. I am a patient and do a lot of work as a patient advocate and patient by experience. I'm also an ex-NHS employee and an ex-social worker, so I'm seeing this sort of 365 at the moment. I think as a concept, particularly with the ability and ease of discharge and what it adds to the waiting list to discharge at the moment, and also the ability for people to stay at home, but not only that, stay safe in their own homes. I think this is really just the tip of the iceberg with regard to how useful this relationship could be between the two services. I suppose my interest in my question today is the patient response and feedback you've had, especially with regard to patients understanding what the roles are of each agency and who's responsible for taking care of them in what way.
In terms of the feedback that we've had specifically from the community, it's been very, very positive. What we have, particularly with the telecare, and in terms of hospital discharge, we've explained that we're coming in. We've explained what we're doing. We've explained who we're acting with or on behalf, depending on how we in terms of that. We've also been very clear about what we are going to do and what we're not going to do in terms of those aspects, because we did have a very discussion about personal care. In terms of what we're doing presently is we'll always make somebody comfortable. We'll always make sure that if they're in distress, make sure that. But as an example, if they needed to be completely bathed and washed or anything like that, we would make sure that carers are coming promptly to undertake that. So it wouldn't be our firefighters who would be doing that at the present moment in time, but we would make sure that the person, we would give them clean clothing, and then they could be, and so they could sort themselves out as such. But in terms of the feedback we've had from people, it's been very, very positive, and very positive from their families as well. Because again, we've got the ability to follow that work up. We've got some people who are firefighters who ride on fire engines, and I'll put it in that way because in our world we like to call them PRLs, but fire engines, who we call vulnerable persons officers. So again, we've given additional training and additional additional training information so that they will work with individuals and on an ongoing basis. We have got case histories where actually we got VPOs who have continually, you know, over a period of time, worked with people over 12 to 18 months to build up competencies, to help them engage with other services, to be the conduit. But I'm also at pains to say we're not social workers. We're not doing that. All we're trying to be is be that person who can actually help that individual to get the right service at the right time in that context.
Brilliant. Thank you, Katie. Always goes right to the heart of what we need to worry about. So thank you for that. It's really helpful. Steve will hopefully give you a gentle question now, although you never know, I might struggle and push you hard here.
Okay.
But Jean's got a question for you.
I'm the West Midlands Fire Service Health Advisor and work closely with Steve and with Pete. And in terms of some of the things that have been referred to, we have a customer care card which we've based on the Friends and Family, the NHS Friends and Family, which we're just rolling out across the whole of the West Midlands because we recognised that in order to absolutely ensure that we completed the circle, that we got feedback from our customers. It's all very well working with partner agencies and our own service, but we really need to find out from everybody that we work with in real terms what they feel about the service we give. And in fact, speaking to our chief yesterday, he suggested that we also develop a customer care card for emergency call out. So that will be interesting. And in terms of whether we should be accredited, we actually put ourselves out there by going for the Royal Society of Public Health accreditation to see if we were fit for purpose. We had to give in, Pete and I had to give in 19 pages and a box file of evidence, plus we were interviewed by people from around the country for a whole hour on the service to make sure that we had a culture and training, because as I heard from the questioner, it's really important that we have a wide range of services that feed our training. So whether it's GAIT, G-A-I-T, that we got from the Physio Chartered Institute, or whether it's dementia training, or whether it's general well-being, Marmot type training. Professor Marmot calls us the new social workers. So we've really tried very hard to not just have MEC or a fixed range of things. We've tried to think about all the issues that are relevant to our client base.
Simon, do you want to add anything onto that?
Yes, I mean, I guess the thing that I found hardest with this is to get people to think about the fire service as a core part of, or potentially a core part of, our health and social care system. And the quote that we had earlier on from Simon Stevens, I think, you know, it was really helpful that he kind of gets it. So it's been useful to kind of describe that to people, which is there is this enormous untapped reserve of professional capacity within the city that's available 24 hours a day, 7 days a week, that we require for other purposes to always be available. So, you know, we require fire service staff to be sitting there waiting for calls to come. The question is what else they can be doing while they're waiting. And I think the forethought that West Midlands Fire Service have had over the last 12 months in coming forward to try and get this in place, and the tenacity that they've demonstrated in really pushing at some of our kind of intellectual boundaries has been a delight. So this is a relatively small scale pilot. We ran it during Perfect Week, which was a really good starting point to get it up and going. It met with a bit of resistance from other blue light organisations. I think that's fair, Steve, isn't it? A bit of suspicion from other blue light organisations.
Yeah, that would be fair. It would be fair that, you know, what is this about? Are you trying to replicate the ambulance service, or you're replicating other agents, you know, in terms of that? And also, what's your qualifications to undertake this?
Yeah, so we had to wrestle with that a little, but we did manage. And it's worked really well. Everybody's kind of a bit calmer about their territory being stomped all over, and we've got to play ourselves past that. So this has been a really good step for us as a health economy. I think it's possibly the beginning of something certainly different on a regional basis for WMFS, but hopefully will form the kind of backbone of some national work that's going to go forward, and thinking about what other roles and functions fire service staff could undertake, and how they can be built in to kind of expand the quantum of resource that we have available at our disposal to improve the outcomes for people within our communities.
And I think, sorry, go on,
sorry,
please.
Just a very quick one. In terms of the hospital discharge, which was done through the Perfect Week, actually, you know, we are carrying that on, and it has been, you know, quite successful. The only thing is, it's small numbers at the moment because it's something new. So, and it's, you know, and one of the, it would be fair to say is, once we've been there, who do we refer the information back to? Which we've actually put, you know, we've worked with partners about who wants to know that, because, you know, one of the key questions was, well, we'll give the information back to the emergency department, and they went, well, actually, with all due respect, we're obviously really caring towards the person we've discharged, but actually we don't need to know. It's who in the next chain of the system needs to have the information that we're gleaming from that visit, and how does that work? So, you know, this is really exciting for us as a service, because actually we're getting to the people who are the most vulnerable in society up front, early on, and being able to work with them. At the same time, we know we're supporting a greater need and the burden that's being placed upon the NHS at this present moment in time, in terms of reducing the amount of time that people need to be in a bed, in a hospital, rather than being back at home.
I agree. Now, I'm just going to read Andy's question out, I think, because we've not quite managed to connect it on the audio. So the first question, which I think you've both hinted at and alluded to, but you might want to answer directly, have any outcomes been measured by this intervention?
The answer is yes. We've had more around the telecare. So we've had some great successes in there where we can clearly demonstrate where what I would, please forgive me for the colloquialism, what I would call you would have termed your frequent flyers, in terms of the frequency they were having a demand on additional services has been reduced, and their quality of life has increased, because obviously they're not having visits by firefighters or whoever else at 3 or 4 o'clock in the morning. And please, can I not have any jokes or reference about firefighters visiting at 3 or 4 o'clock in the morning on that one? But you know, in terms of they're not getting that, so, and that's been really positive. But the numbers in terms of the hospital discharge are very small at the moment. I did cite to you during the presentation one that I would call a great success story, and this isn't, you know, and in terms of this person was appropriately discharged from a hospital. There was no clinical reason for them to be held in hospital, and yet when we got there, they had all the doors were open. Something had happened to them, and they were collapsed in front of a fire. And it is quite likely they would have suffered either a serious injury or perhaps something worse if we hadn't had this hospital discharge protocol in place and we'd gone round there to check them. So, you know, in terms of, for me, what is the cost of somebody dying? What is the cost of somebody being, you know, really serious injury on the health service? And more importantly, what is the cost to the community of that person suffering from that? So the numbers are quite small on that part, but we've got some quite, I think, very positive numbers with regard to the telecare aspects and reducing calls and supporting their quality of life in the home.
And I think we're always quick to measure, you know, the kind of hard statistics, but the soft statistics of, you know, the emotional trauma of falling over or having to be admitted or whatever to the individual and their family can't be underestimated. Would be my bit I would add to that. So the next question, which kind of a bit builds on that really, where Andy says he can see the value for the fire service with the early discharge, allowing pressure around beds being blocked, but has any work been carried out prior to admission, e.g. carrying out risk assessment prior, which could have prevented falls?
Yes, that's what we call our safe and well visits. The UK Fire Service, many years ago, I think it was called, it wasn't even DCLG at that time, it would have been prior to that, started by, they gave us quite a large amount of money and basically said, go out there and give everybody smoke alarms. But what we soon found out actually is you can fit smoke alarms as much as you like. It's the behaviours that you need to be aware of, and the life changes is just as important. So that has morphed now over the last 10 years into a safe and well visit, where we're actually looking at health aspects and referring those on, and it's a more holistic risk assessment or discussion with individuals when we go in their home. So that's what we would call our upfront, and we look for those referrals from our partner agencies, from the health service. We would really like to kind of get, you know, GPs to say, actually, these are the most vulnerable on my books at this present moment in time, and actually, I wouldn't mind the fire service going and having a look and, you know, and getting a feel for what they would see. Not making clinical decisions, just going around and going, actually, is this person living in one room? Is this person, from your opinion, maybe needing to be having looked at? I haven't seen them in years, but in terms of the profile of vulnerability, which we all are growing to know, they fit the profile. So actually, could you go and have a look? Because actually, they're the same people who are likely to get injured and die in our fires. You know, if you look at, we know who die in fires, we know who's more likely to have fires, because we had a group of, you know, 25 to 45-year-old men living alone, unemployed more than 12 months. Suddenly sprang out to us. So actually, if I go into the health world, I know that you're having a similar cohort of men unemployed who may be suffering from mental health issues. So actually, is there some work we could look at in that direction as well as part of our safe and well visit? So the opportunities to understand each other's complex worlds and then really honing in of, okay, we could be your frontline eyes and ears. We can be there within this time scale. We could pass on this information to you that might be useful in preventing things. So those are the kind of things that we're doing upstream.
Brilliant. And just two more questions before we end. So can you advise how the handover to social care with discharge and how the fire service works into that model? Does that make sense?
Yeah, what we've been doing is we've been passing our information back to a central point, so looking at it to be de-escalated. So, you know, in Coventry, we've got a central number that we pass on all that information to. If it's the telecare, we pass the information through telecare, who then distributes it to the appropriate agencies or the carer. And in the discharge, we've got a central number that we would pass that in through. And again, they may use agencies such as Age UK, or actually internal services within the health sector or in the local authority, or it might be that we might be doing a follow-up visit in terms of further safe and well vulnerable persons.
And we agreed that set of thresholds very early on, didn't we?
We did, yeah. Because it was very important. It was very important for us in terms of closing the loop for that person. In terms of, if we've got some information, it's no use us just holding on to that and not passing it on, because then it becomes useless to anybody else.
Okay, so we've got just quickly on to the last one. As part of the referrals, are the fire service carrying out some care of social assessment? And what does this assessment include, e.g. stability and mental health, which again, I think you've mentioned some of that throughout the presentation and the conversation.
And in terms of this, the answer is yes. It really is the safe and well. And what I would say is the safe and well visit. Again, I gave the email address out earlier, but if you contact, if you contact Pete Wilson on pete.wilson@WMFS, or if people who know Jean, it would probably be worth having a look at what we look at in terms of a safe and well visit, because we cover quite a lot of those. And we're looking to adapt it and change it and refine it all of the time from, looking at working with our partners about what information is critical for them. I mean, what we would like to do in the future is have the ability to automate it, so any information we glean could automatically send to our partners. We have talked about, something where, we have an iPad and we can take a picture while we're talking to somebody, and that information could be downloaded by a GP and they could see what that is, and they could actually see the environment, or the health nurse could see it. So you get a real feel for what you're going into and supporting. And that's not to take away or detract from their role, it's to enhance their role, because we're passing on the appropriate and pertinent information about the person that we're having contact with.
Brilliant, brilliant. I think that circles it very nicely. So thank you to everybody for joining us. And finally, to turn back to our two presenters, really just to say thank you to you both. I think it was really helpful, and it's the start of something. I think, as Simon mentioned earlier, in the CCGs we're working with across England, it's not easy to move this forward. So we just need to keep pressing on and keep giving good examples of it. But I just want to ask you both to just give, one thing that people could do when they leave this call. There's obviously ambitions for the future, but what's the one thing that they could do when they leave this call now and get going on their journey working with the fire service? So,
come on, Simon, I'll let you go first.
I think be hugely open-minded. I don't think there's a limit, really, to what can be achieved. And there are a number of fire services that have paramedically qualified firefighters, for instance. So if you think about the whole range of opportunities and thoughts and possibilities that there might be, start with an open mind and see where you get to.
Okay. And mine would be, is basically, I think the problem that you have is trying to understand each other's worlds and see how they come together for the betterment of the person in that home. And I think if we can walk a mile in each other's shoes, I think we'll find actually in terms of what creates the KPIs, the performance figures and everything that we can think about, we can actually understand that actually we have a lot to help each other with, and a lot of the solutions that can make a difference are very easy to do, and they're very practical based. And what I would say the fire service has got to offer the health sector is we've got a can-do attitude, we love problem solving, and we actually love the community and we love working with them. So let's walk a mile in each other's shoes, build those relationships with your local fire service, and let's see what we can do together.
That's brilliant, brilliant. Thank you both. It was a really good session, so well done, and thank you for keeping your energy up, and wish you all a good afternoon. So thank you very much.
Thank you. Thanks for the opportunity.
Bye.